Hello, my name is Stefan John. Today, me and my colleagues are going to talk about the endodontic therapies in primary teeth. There are several endodontic therapies that can be done on primary teeth to preserve the vitality of a tooth. One such procedure is called indirect pulp capping. In indirect pulp capping, we are trying to preserve the vitality of the tooth by leaving a thin shell of affected dentin right above the pulp so that the carious lesion does not leach into the pulpal area and necrose the tissue. In this procedure, what we are going to do is leave a thin shell of affected dentin and place a thin layer of calcium hydroxide over it and seal the tooth either with a temporary restoration or a permanent restoration. With the temporary restoration, we are going to seal the tooth with zinc oxide eugenol or glass ionomer cement. But with the permanent restoration, we are going to seal the entire tooth with a bonded cement or a stainless steel crown. According to Srinivasan and Patchett, a single-stage indirect pulp capping is recommended over a two-stage pulp capping. The reason for that is because the primary dentition has thin layer of dentin, and a re-entry into the pulp chamber can induce a pulp exposure. Coming to direct pulp capping. The American Academy of Pediatric Dentists do not recommend doing a direct pulp capping on a primary tooth. However, if the tooth is subjected to an iatrogenic pulp exposure or a mechanical injury, under sterile conditions, we can do a direct pulp capping.
Hi, my name is Noor and I will be talking to you about pulpotomy in primary teeth. So, pulpotomy, according to the American Association of Pediatric Dentistry, is the technique and procedure of removing and amputation of all the infected or affected dentinal pulp in the coronal portion of the tooth and preserving the function and health of the radicular part of the tooth. So, what are the indications for the pulpotomy in a primary teeth? Any tooth with pulpal exposure, but we are making sure that it is the inflammation or infection is confined to the coronal part of the tooth, this tooth will be an option for pulpotomy. But if the inflammation proceeds to the root canals, then that means this tooth should be considered for pulpectomy, root canal treatment, or extraction. What are the contraindications for pulpotomy? So, any tooth that is in its exfoliation time should be extracted because the permanent successor will be emerging at that time, so no need for pulpotomy. Another thing is any tooth that we cannot restore after the pulpotomy procedure and to obtain coronal seal should not be considered for pulpotomy. Also, any tooth with previous history of spontaneous pain or any serous or purulent drainage, any tooth with necrotic pulp or any tooth with resorption, periapical or furcal resorption, all of these teeth will need root canal treatment, pulpectomy or extraction and are not candidates for pulpotomy procedure. So what is the technique for pulpotomy? First of all, after a good diagnosis, after taking the history and examining the radiographs very well and taking history from a patient, a child patient is very hard because they keep forgetting and they will not give you a specific signs and symptoms. So you have to have a very good radiographic examination and clinical examination to decide if the inflammation is confined to the coronal part of the tooth, which is the indication for pulpotomy. So after doing that, we should anesthetize the tooth and then isolate it with a rubber dam, and then we remove all the carious lesion, and then after the exposure, if it happens, then we should remove all the roof for the pulp chamber and remove all the pulp tissue in the coronal part of the tooth. And then we should do that with caution, using slow speed with round burr, like number 6 or 8, or a spoon excavator. After that, we should irrigate with water or normal saline, and then we should obtain the hemostasis. We will have hemorrhage from the root canals. If there is no hemorrhage, that means the tooth is necrotic and will need extraction or root canal treatment. If there is hemorrhage, we should control the hemorrhage. So using a cotton pallet, we should wet it first, dry it, and then put it there. We cannot use a dry cotton pallet because the fibers will be incorporated into the clot and there will be a hemorrhage again. So apply this cotton pallet, the wet one, and then another one which is dry. Apply pressure for 3 minutes and then remove it. If you obtain the hemostasis, that's good. If not, then we should redo the procedure again using the pellets. If we didn't obtain hemorrhage after the 2 trials, that means the tooth is the tissue in the root canal is inflamed, and root canal treatment, pulpectomy or extraction should be considered again. If we obtain the hemostasis, then we have options to use the dressings. We can use formocresol, we can use MTA, we can obtain hemostasis by using ferric sulfate or even laser or electrosurgery. According to a study that is published in March 19, 2020, they did a systemic review for all the cases, like more than 4,000 cases, until October 2019. And they have their results saying that the MTA is the gold standard nowadays for the pulpotomy procedure. Also, the biodentin has a promising results, but the calcium hydroxide was the worst of them. Formocresol was very popular for a very long time for the pulpotomy because of its ease technique, but because of the formaldehyde, which is a content in the formocresol, which is mutagenic and toxic, so it should be used with caution nowadays. So the MTA is more recommended now than the other procedures, and also more clinical trials are needed just to make sure that which one of these dressings is the best. Thank you.
Hi, I'm Jillian, and today I'm going to talk about pulpotomy in temporary teeth, the formocresol technique. Following the coronal pulp amputation, and after we have a really good hemostasis, we remove the excess of one pellet with 1/5 dilution of formocresol and place it in direct contact with the pulp for about 5 minutes. Remember that the formocresol is caustic, so you need to really be careful or you can burn the tissue. When the pellet is removed, the tissue looks really brown and no hemorrhage should be evident. If an area of the pulp is not in contact with the medication, we need to repeat the procedure. Remember that small cotton pellets works best because they allow closer approximation to the tissue. Now, after that, a cement base of zinc oxide agenol is placed over the pulp. The tooth may then be restored. If we want to use a metal prong, we're going to place it on the molars. And if for any reason we need to restore an anterior teeth, we're going to use a composite tooth color restoration, unless that this tooth is broken down.
Nowadays, the use of formocresol in dentistry remains controversial. Formaldehyde is an organic compound that is toxic and really corrosive, especially at contact. Localized accumulation of formocresol has been demonstrated in pulp, dentin, periodontal ligament, and bone surrounding the apices of pulpotomized teeth. Although animal studies have been identified high levels in major organs following systemic injection of multiple pulpotomies, the dose we use in normal clinical practice are really small. Therefore, the findings should not be extrapolated to the clinical use. Now, is formocresol really carcinogenic? It is generally accepted that formocresol is genotoxic in vitro, inducing mutations of the DNA damage in cells from a variety of organisms. In a review of several large longitudinal studies, we see evidence that formocresol had caused nasopharyngeal cancer in humans, but this was linked to localized combination of irritation and genotoxicity of formocresol. Despite these concerns, the formocresol pulpotomy continues to be one treatment of choice available for primary teeth worldwide. In the United Kingdom, in 2004, there has been some general trend away from using formocresol. driven by different factors. However, the recent UK clinical guidelines still includes the formocresol as a pulpotomy option. On the other hand, there is a study named Use of Formocresol by the pediatric dentists across the United, conducted in India in 2020. 50 pediatric dentists were questioned about the use of formocresol, concluding that formocresol is widely used. Now in the United States, is still taught in predoctoral pediatric that there is a lack of consensus over the use of formocresol for viral pulp therapy in primary teeth. The current formocresol pulpotomy technique is a modification of the one reported by Sweet in 1930. There are many factors influencing the outcome besides the concentration of the formocresol. After a deep debate, there is enough evidence today that conclude that the 1/5 concentration should be preferred for pulpotomy because it is effective and is less caustic, less toxic than the traditional preparation. Now we can say that the fear of damage to the succedaneous tooth has been offered as an argument against the use of formocresol in the pulpotomy on primary teeth. There are some studies finding no consistent effect on some reporting early exfoliation. For example, Rollin Paulson's made one study called the formocresol pulpotomy of primary teeth and the occurrence of enamel defects on permanent successor teeth, dated in 1978, where 52 permanent teeth on 35 children. We evaluate what happened after the use of formocresol on the permanent. The conclusion is that in this study was that there is no relationship between the formocresol pulpotomy on primary teeth and enamel defect on permanent successor. And finally, we say, what is the criteria for success? The failure of formocresol pulpotomies is usually detected on radiographs. The first signs of failures are often internal resorption of the root adjacent of the area where the formocresol was applied. Now, this may be accompanied by external resorption, especially as the failure continues to progress. Sometimes, however, the internal resorption is self-corrected with the deposition of calcified tissue. In the primary molars, radiolucent are specifically in the furcation area, and in anterior teeth at the apices of lateral of each tooth. With more destruction, the tooth becomes excessively mobile. A sinus tract usually develops and is ready for pain to occur with the failure of formocresol pulpotomy. These findings emphasize the importance of periodic follow-up to endodontic treatment on primary teeth.
Hello, I'm Alba and I'll be talking about the alternatives to formocresol pulpotomy. And it's three of them: glutaraldehyde pulpotomy, ferric sulfate pulpotomy, and MTA pulpotomy. So let's start with glutaraldehyde. Histologic findings have shown that glutaraldehyde has a rapid surface fixation with limited depth of penetration, and so fixed tissue gets replaced with collagenous tissue over time. Glutaraldehyde is rapidly metabolized with limited depth of penetration, as I mentioned, and also it gives us less systemic distribution compared to formocresol. But there are a few downsides of glutaraldehyde, and it has been shown that has lower level of clinical success. Glutaraldehyde solutions are unstable and there is not an established concentration or optimal time of application. For this reason, there is no clinical application of glutaraldehyde on the pulpotomy. So let's go and talk about ferric sulfate. Its first documented use in primary teeth was as a hemostatic agent during calcium hydroxide pulpotomy. The hemostatic action occurs by the reaction of blood with ferric and sulfate ions within the acidic pH of the solution. Ferric sulfate is largely used nowadays also as a hemostatic agent during crown or bridge impressions. So let's go through the steps and the technique of pulpotomy with ferric sulfate. First of all, we start with the pulp amputation, and then we try to reach the hemostasis using moist cotton pellets deepened in a solution of 15.5% of ferric sulfate, and we leave it on the pulp for 10 to 15 seconds. After that, upon removal, we should see that the pulp is brown and there should be no blood in there. If we see that there is still blood, then we can just go and do a second round of ferric sulfate. After that, and after everything is stable, we place a cement base of zinc oxide eugenol on top of the pulp stamp. So over the years, a few studies have been done trying to compare the success rate between ferric sulfate and formocresol, which was considered the gold standard back then. And I want to mention a couple of them. Let's start with a study done by Fay, Udin, and Johnson. They divided the teeth in two groups. In the first group, they used formocresol, and in the second group, they used ferric sulfate. This was a 1-year-long study, and in the 3-month, 6-month recall interval, there was no statistically significant findings or differences between the two groups. But what's interesting is that at the end of this 1-year study, there was a difference in the success rate in favor of ferric sulfate on a report of 97% over 78% for formocresol. Another interesting study is a retrospective study done now, where this was done in the 2000s, and in the study were evaluated ferric sulfate pulpotomies performed by a private dentist over a period of 5 years. Clinical success rate after 36 months was very high. It was up to 99%, and the estimated survival time was high. On the first 10 months it was like 99%, and after 43 months still it was high. It was on the range of 80%. So over the old studies that have been done, the main conclusion is that both as ferric sulfate and formocresol pulpotomies have good clinical results, and ferric sulfate can be used instead of formocresol for the treatment periods of up to 36 months. So that's it. Thank you.
Hi, I'm Susanna, and today we're going to be talking about MTA pulpata. So after you have removed the portion of the pulp from the pulp chamber, the first thing that you need to achieve is hemostasis. The easiest way to do it is using a cotton pellet moist. After you have achieved hemostasis, you have to mix the powder of the MTA with sterile water. You mix it until you get a sticky consistency. Once you have your MTA ready, you're going to place it over the remaining pulp tissue. You place the MTA, and after that, you're going to cover it probably with glass ionomer. You need about 3 to 4 millimeters. Because the MTA takes several hours to reach its stability, you need to protect it with something like the glass ionomer, and then you can restore the tooth as normal. Several studies have been done which show that MTA is better than formocresol and calcium hydroxide. According to Dominguez, in an article published in 2003, it was proven that MTA has better abilities of maintaining the remaining pulp tissue, and it also helps create a dentinal bridge, which helps restore the pulp tissue. Thank you.